Right, terrific. Thank you for the introduction. I just changed the title into a much more comprehensible one, which would be, should the definition of sarcopenia include muscle mass, or lean mass rather? So by way of a quick background, sarcopenia refers to muscle mass loss during aging. And in 1988, the first definition of sarcopenia was developed, and low muscle mass was adjusted for either height squared or weight. And if you had low muscle mass, you were considered sarcopenic. However, in the next decade or so, the research very clearly showed that these early definitions of sarcopenia were not associated with adverse health-related outcomes, such as mobility limitations, falls, activities of daily living disability, or mortality. However, it's very important to note that when muscle mass is referred to in the sarcopenia literature, over 95% of the time, what the authors really mean is lean mass. And lean mass consists of muscle mass, organs, bones, body water, as well as skin. And it's quite well known that lean mass is not a particularly good proxy measure for muscle mass. So the issue isn't necessarily with muscle mass, but rather with lean mass as a surrogate measure for it. So to overcome the limitations of lean mass, sarcopenia definitions began to be broadened in the early 2000s to include muscle strength, typically measured by grip strength, or muscle function measured by gait speed, as well as introducing two new adjustment techniques, either adjusting for body mass index or regressing on height and fat mass. These more elaborate definitions for sarcopenia are associated with all of the health outcomes that you would think sarcopenia should be associated with. However, muscle strength and muscle function on their own are also associated with those outcomes. And what is clear based on the literature is if sarcopenia defined as lean mass in either muscle strength or muscle function performs any differently than muscle strength or muscle function all by itself in terms of identifying individuals with disability, as well as other outcomes. And this is important because sarcopenia is now included in the International Classification of Diseases, meaning physicians are diagnosing and presumably trying to treat sarcopenia. However, if lean mass is not really contributing to those associations with adverse health outcomes, how do you justify the increased cost and the participant or patient burden associated with measuring lean mass? And furthermore, there are quite a lot of different drugs being developed for sarcopenia, and the vast majority of them have lean mass as their outcome that they're trying to improve. But again, if lean mass in itself is not really contributing to the association of sarcopenia with health, is that really an appropriate target? The objectives of my project were first to compare the association of grip strength and gait speed alone versus in combination with lean mass with disability, and secondarily to assess the discriminative value of sarcopenia for identifying individuals with and without disability. And this second point is quite important because a lot of people in the sarcopenia literature make the mistake of assuming that just because sarcopenia is significantly associated with different health outcomes based on using odds ratios or relative risk, that it means that it's clinically useful, but that isn't necessarily the case. I used data from the Canadian Longitudinal Study on Aging for my analyses. The CLSA is a national longitudinal research platform, which includes over 51,000 participants who were randomly selected from 10 Canadian provinces. And these participants were aged 45 to 85 years at baseline. I only used about 30,000 participants from 7 provinces who were included in the comprehensive cohort. The other 20,000 participants are part of our tracking cohort, and they're only contacted by phone. Therefore, they didn't have the data required to diagnose sarcopenia. The most challenging part of this project for me was coming up with a way of operationalizing sarcopenia. There's about a dozen or so definitions available in the literature. Most of them are called expert group definitions, which I always laugh at. So instead of trying to pick the best one, because there's absolutely no guidance about which one is best, we took the approach of covering all the individual components and including them together. So we cover the entire breadth of how sarcopenia has been defined. So for lean mass, we adjusted for the 4 different techniques: height squared, weight, body mass index, and regressing on height and fat mass. And there aren't many cutoffs suggested in the literature for all 4 of these. What we did was we used the lowest sex-specific 20th percentile values as a cutoff, with sensitivity analyses using the 10th and 40th percentiles. And we had 2 different cutoffs for grip strength, which was our measure of muscle strength. And for muscle function, it was measured by gait speed, and we used a cutoff of 0.8 meters per second. And we looked at all combinations of these methods of adjusting for lean mass plus muscle strength, and again with gait speed. We had two outcomes, which were basic activities of daily living disability and instrumental activities of daily living disability. And we considered participants who were having a problem with at least one domain of each of these sets of variables as having a disability. So basic activities of daily living include things like getting in and out of bed and bathing that are tasks that are required for day-to-day living if you're to be independent. Instrumental activities are also daily tasks that must be done or semi-regularly, but are a bit more involved, including things like grocery shopping and managing medications. For our statistical analyses, we further limited our sample to participants of European descent, age 65 years and older, since you don't tend to see sarcopenia in people much younger than that, and those who had the data required to diagnose sarcopenia and determine their disability status. So we had a final sample size of just under 10,000 people. We stratified our analyses by sex, and we conducted logistic regression models using those basic and instrumental activities of daily living disabilities as an outcome. And we conducted area under the curve analyses to assess the discriminability of each of the sarcopenia definitions. So these results here are referring to basic activities of daily living for the traditional sarcopenia definitions, including just lean mass in men and in women. So what we found was very consistent with the literature, which was showing that the vast majority of the lean mass-based definitions, regardless of how lean mass was adjusted, were not significantly associated with basic activities of daily living disability in men or in women. And there was one exception with weight-adjusted lean mass in men, but certainly the magnitude of the association was quite small. And in women, interestingly, we even noticed that there is a protective effect of having low lean mass, depending on how it's defined. Looking at definitions, including grip strength alone, what we found is that grip strength was significantly associated with an increased odds of disability in both men and in women. And once you added in lean mass to grip strength, they weren't significantly different from grip strength alone. And in fact, the point estimates in some cases were even lower than just grip strength. And that was true in men as well as in women. And we found very similar results looking at gait speed. Gait speed was, on its own, was significantly associated with disability. And the point estimates were not significantly different once lean mass was adjusted. And I do apologize, I just need to cough for 1 second. Sorry, my household has been struck down by COVID in the last week. And just a further point to these analyses, I'm not showing you today for brevity the instrumental activities of daily living, but the analyses, the interpretation was exactly the same as the basic activities of daily living. And the interpretation also didn't change when I started using all the different cutoffs in my analyses and possible different combinations. So the results were remarkably stable. For the area under the curve analyses, we found that all of the definitions had area under the curve values between 0.50 and 0.60. And to contextualize what that means, you can simplify the interpretation of A's area under the curve to say area under the curve of 0.5 is no better than a coin flip in terms of knowing if someone has disability based on their sarcopenia status. And certainly these values were well below 0.70, which is considered the threshold for clinical relevance. So of course, our study has strengths and limitations like all studies. So our strengths include conducting very extensive sensitivity analyses. I challenge even my harshest critic to find a way of defining sarcopenia that we haven't encompassed in our approach. And our size allowed us to do our sex stratified analyses, which is quite important in the context of sarcopenia. In terms of limitations, we do have limited generalizability because we only ran our analyses in people of European descent. And though cross-sectional analyses is generally considered a limitation, in our case, there's a bit of a strength. because the sarcopenia cannot adequately classify participants with prevalent disability, and there's certainly a bidirectional association with sarcopenia and disability, then it's definitely not going to have adequate discriminatory ability for incident disability, which is really what the goal of diagnosing sarcopenia is. You want to identify people before they develop issues. So in conclusion, we found that lean mass alone is not associated with disability, but that grip strength and gait speed alone are. We found that measuring lean mass in addition to grip strength or gait speed does not change the magnitude of the association of disability, and that all the sarcopenia criteria, as well as the combinations of criteria, did not have sufficient discriminatory accuracy. Based on all of these combined together, this suggests that the role of lean mass in measuring sarcopenia needs to be And I'm certainly not alone in this belief. In 2020, the position statements of the sarcopenia definition and outcomes consortium was published. And this group asked a panel of experts about their agreement and disagreement with various aspects related to defining sarcopenia. And all of the experts unanimously agreed that lean mass is not a good predictor of health-related outcomes. However, 50% of the experts said that lean mass only 50% of the experts said that lean mass should not be included in the definition of sarcopenia. So there are people that believe that lean mass should continue to be included in definitions despite the lack of association of lean mass alone. But to my knowledge, we're the first people that have ever actually shown that lean mass, even when added to grip strength or gait speed, still doesn't have any sort of effect, which I hope is very compelling evidence for those 50% of experts who would like to see lean mass be excluded from future definitions. I would like to acknowledge all of my collaborators as well as the participants of the Canadian Longitudinal Study on Aging, and I would be delighted to take questions. And again, my apologies for the coughing.